Good morning, everyone. I hope everyone got out to go to the fun run. Yes? Did everyone have fun running? How many had fun sleeping? Right. How many know what a sunbreak is? Sunbreak? So you're not from Portland. Okay, so that's when it stops raining. Okay. So I actually am not going to talk about research. I'm going to talk about lung cancer screening, and I need to figure out how to make it go. Here we go. The learning objectives are shown on this slide. So first we're going to understand the concepts of cancer screening and inherent biases of uncontrolled trials. We can evaluate the completed lung cancer screening trials and to apply the data from the completed lung cancer screening trials to practice in the VHA. And in the interest of giving you the answers up front, here they are. Answer to learning objective 1 is that randomized controlled trials with mortality rate as an endpoint is the best way to assess efficacy of screening, not only for lung cancer but for all cancers. The results from the largest completed trials is shown here. 20% mortality reduction from lung cancer, but lots of risks. And the final answer is that the VA is conducting a pilot study at 8 sites. Okay, I have no relevant disclosures, and I was told to specifically say that lung cancer screening is, as far as I know, is not regulated by the FDA, and so there's no off-label indications. All right, so I'm going to talk about the principles of cancer screening, talk about studies of chest X-ray and sputum cytology, then chest CT scanning as a modality of lung cancer screening, and finally describe the VA's screening pilot program. The principles by which screening trials are designed have evolved over time. So in the 1960s, there was a proposition put forward by Wilson and Junger with the World Health Organization that was based on essentially intuitive principles of what made sense to them. So that heuristic has been applied to cancer screening, and I think some of us grew up learning these principles, and those principles included that the condition sought was an important health problem, which lung cancer clearly is. It's the largest cancer killer of both men and women in North America. There should be an accepted treatment for patients with recognized disease, and treatment should be better at an earlier stage. Facilities for diagnosis and treatment should be available, etc., right down the list. And there's one of these that in particular that is somewhat problematic, and that is this one here. This is true for many types of cancers, that the natural history of the condition, including the development from latent to declared disease, should be adequately understood. And I think the key word there is adequately. So when you look at the development of disease from precursor lesions, do we really understand what is going to become a cancer which causes disease as opposed to that which is a cancer only to the pathologist? Okay. Oops, no. So let me just give you some examples of what I mean by this. Is there a pointer on here? Is there a pointer?
We can see your mouse.
Okay, oh, there it is. Got it. Okay, I couldn't see the mouse. All right, so we as clinicians know that there's heterogeneity in patients as they present to us. So on this slide, we're mapping time, and this is time, very long periods of time, maybe decades, and this is the tumor size on the vertical axis. And so for some patients, we know that they present with disease here at this dashed line, and they have very rapidly progressive disease and then die at a very short time. And then there are other patients who have slower growth, present at this point, and then come up and have a longer survival. So the survival is measured from this point to this point. And that varies quite a bit. We are very good at predicting survival for groups of patients, but we're still very bad at predicting survivals for individual patients. So it's difficult or impossible for us to understand for an individual patient what their prognosis is. There are other groups of patients for whom the growth of a tumor is very slow and to the point where it is present at autopsy but not clinically apparent. And then there are some tumors which actually do not progress at all. They develop but then do not ever really cause anything that is even recognizable to the pathologist. If you do a screening test, again, there it is here. If you do a screening test here shown in this vertical line, you can move the diagnosis point from here at the point of symptoms to some asymptomatic period of time, but what you don't know is whether you actually increase the, you change this point of death. So you can increase the survival case rate by having an earlier diagnosis, but you don't necessarily improve when the patient actually dies. So this is the lead time bias. Oops. Okay. There's also overdiagnosis bias, and that is a worst case scenario for lead time bias, in that you can diagnose patients with cancer, like these two patients on these lines down here, but they never would have been diagnosed with cancer in their lifetimes. Those are just some examples of biases of screening. So instead of this, this intuitive heuristic that the WHO prescribed, the U.S. Preventive Services Task Force proposed a different model, and this was described in 2001, and that is an evidence-based framework for screening. And it's basically a concept which I think we all understand in oncology, and that is that you do a randomized controlled trial and compare outcomes. And in this case, you're doing a screening test here at this point to have early diagnosis and then treatment, as opposed to a cohort of patients which are diagnosed at the point of symptoms or some other incidental finding, and then they both are compared for an output which is, endpoint which is reduced morbidity or mortality. That is, do patients live longer or do they live better, which is what we always ask. And in this case, it's the mortality rate for the cancer that you're screening for, which is the important endpoint. So we talked about some of the biases, lead time bias, overdiagnosis bias. There's also healthy volunteer bias, that is in single-arm studies, people who volunteer in uncontrolled studies, that disease which is present in those individuals has a different natural history than disease which presents in patients who present with symptoms. You avoid those by doing prospective randomized controlled trials, well-designed ones, and you use cancer-specific or overall mortality rate as the endpoint. And there are some other endpoints which should be considered inadequate for high-level decisions. That is looking at stage shift, so do you have an earlier stage at diagnosis, which is necessary but not sufficient, and also looking at case survival rates is also necessary but not sufficient to show that there's improvement in outcomes for cancer screening. Okay, so there have been chest x-rays that were used over a period of several decades now to look at its efficacy in reducing lung cancer deaths. There are at least 5 completed studies. I have some data on 4 of those shown on this slide. And just to sort of give you a sense for what some of the results look like, I've put some of the highlighted results here. So the Northwest London study had 50-some thousand men. They were all 40 years or older smokers. The intervention arm was chest x-rays every 6 months for 3 years versus a chest x-ray twice at the beginning and the end of the study. The 5-year case survival rate improved greatly from 6% to 23%, but the mortality rate was essentially unchanged. So you can improve the case survival, but you cannot, there was no demonstration of an improvement in mortality. In the United States, there was the Mayo Clinic study, which was chest x-ray and sputum every 4 months for 6 years versus usual care, which was an encouragement to have an annual chest x-ray and a sputum cytology. And there were an increased number of cases in the screen group, the increased 10-year survival rate, but there was not a statistically significant difference in the terms of mortality from lung cancer. The power of this study, though, was not very great. And then there was a Czech study, also similar size, had very similar outcomes, again, not necessarily powered to be not to detect a they were underpowered to detect a clinically meaningful difference in lung cancer mortality. And then finally, recently published was the PLCO study, sponsored by the U.S. National Cancer Institute, a very large study looking at 4 different cancer types, one of which was lung cancer, 150,000 men and women. These were relatively low-risk individuals as a whole. The intervention was chest x-ray annually for 3 years versus routine care, which was not a specific recommendation for any screening for lung cancer. The incidence of lung cancer in the two groups was actually very similar, 20 versus 19 per 10,000 individuals. And the mortality was no difference, with a relative risk of almost exactly 1. So lung cancer screening by chest X-ray is not an effective modality. There were also 2 studies for lung cancer shown on this slide, very similar designs, almost identical, 10,000 male smokers. And the bottom line here is that there's really no efficacy at all in looking at sputum cytologies. The stage was nearly identical, as was the outcome from the lung cancer cases and the mortality rate. All right, so the game kind of changed in the late 1990s when Claudia Henschke and colleagues described the Early Lung Cancer Action Project. This was using low-dose CT scan screening and chest X-ray, and what she showed in this study, which was published in 1999 in Lancet, was that the CT scans were able to detect 27 lung cancers in this group of 1,000 individuals, whereas chest X-ray only detected 7. So that was an increase in case finding. There was an expansion of that through collaboration with many other sites, so at Mayo, Pittsburgh, and then internationally, tens of thousands of individuals, and that was reported in the New England Journal, and that in 2006, and this was about 30,000 individuals. And what this indicated was that of the 410 cancers diagnosed at baseline, 74 at follow-up CT scan, 85% of those were clinical stage 1. So you see a stage shift by historical comparison, and the estimated 10-year survival rate was 88%. Now, I just told you that this is not sufficient to reach a high-level evidence bar to implement screening. There was quite a bit of discussion, it actually started in the late 1990s, about whether this was sufficient or not. And I think that was very informative to looking at screening in other contexts and other diseases, some of which are still controversial, because some of the arguments that are being made now for my favorite topic, hepatocellular cancer screening, are echoes of what has been made for lung cancer screening and prostate cancer screening and others. Okay, so I'm sorry, this is kind of a very light slide. I hope it shows up on your electronic versions of this. These are all of the completed, not even completed, these are all of the known randomized controlled trials of low-dose CT scan screening. And I'm sorry, it's cut off on my slide. I hope that's not true on the electronic versions. But there are 3 of these. This is the one right here. This is, we'll go into this in more detail, but the National Lung Cancer Screening Study is the one which is powered to be, to answer the question relatively definitively, and the rest of them are relatively small in size. You can see that they range from about 16,000 individuals all the way down to just a few hundred. Okay, so that result was splattered across the major media in 2010, when the NCI concluded this study in October 2010 with an announcement that CT scans reduced the mortality from lung cancer. And let me go through the design of this study. These slides are courtesy of Chris Berg at the NCI. So the eligibility was age 55 to 74. The individuals had to be asymptomatic. They had to have at least 30 pack years of smoking and quit within the preceding 15 years and never have had a diagnosis of lung cancer. Okay. The screening was done in 3 annual screens. So at baseline, T0, and then T1 and T2. And the control arm was chest X-ray. So individuals were randomized 1-to-1 to either get CT scans or chest X-rays, and the final analysis was done in 2010. So you can see the size of these studies and how long they take, so you can't do a lot of these studies. Compliance was very good, over 90% in both arms. The population that was enrolled in this study is not necessarily the same as the U.S. census population, and it's clearly not the VA population. So the difference was primarily in terms of education, and there were a relatively small number of African Americans and Hispanics enrolled in this study. So some have characterized this as the rich, highly educated white people study. And that's unfortunately true for many of our studies. So the number of positive screens is shown on this slide. There was a very high positive screen result in the CT arm. So over a quarter of patients on each screen had some abnormality which was ruled as positive. By the third screen, this number declined, but only because of the stability of lesions, which then led that abnormality to be changed from positive to negative. In the chest X-ray arm, there were also false positives, but it was much lower. Okay. So this is just looking at the true false positives and negatives. You can see the false negative rate is extremely high, 96% overall, which is a characteristic which is, I think, interesting and requires some further discussion. But let me get down to the mortality difference. So the mortality reduction in the CT arm was 20%, and the overall mortality, so this is for any cause mortality, was just under 7%. Here are the slides. The survival curves. This is, I think, a little bit difficult to understand for an oncologist because the timeline is so long here on the x-axis, but yeah. So here you see this is the lung cancer mortality rate. So the CT screening is on the solid lines, and the chest X-ray screening is in the dashed lines. And there's a difference that's statistically significantly different. It's not, you don't avoid all the deaths, right? Still 80% of people die of lung cancer who would have died of lung cancer. The X-ray exposure, the radiation exposure from this technology is not that great compared to standard X-rays, so it's an acceptable level of exposure. All right, so then the U.S. Preventive Services Task Force did some modeling. They looked at several, I think 5 different populations of patients, and came up with several different models and compared them, their operational characteristics, and I've just pulled out 2 slides to show what that looks like. So again, the y-axis label is cut off here, but this is the number of scans, and this is the, I think this is the percent reduction in mortality. Oops. So you can see that this is the characteristics of the population, of how the population was selected for the screening that was done in the National Lung Screening Study. So the age was 55 to 75 years, the minimum PAC years is 30, and the former smokers had to have quit within 15 years. So that's what those 4 numbers mean. Minimum age, maximum age, how many PAC years you smoked, and then how long that you could have quit as a former smoker. And they looked at different characteristics, different population selection criteria, and what they ended up doing was recommending this one here, which is more expansive in terms of the upper age limit compared to the National Lung Cancer Screening Study. And that you can see two things about this curve is that the slope of the curve begins to flatten out quite a bit. So you do many more screens as you lessen the risk of lung cancer in the population. You'll do many more screens to get the same increase, the same net increase, the incremental increase in the reduction in mortality from lung cancer. So, and then the second thing is that there's not a great difference between these 2 time points here, these points with the upper age limit of being 75 and 80. Okay, and this is just showing the number of people who avoid death from lung cancer on the y-axis here. All right, so here's some of the risks and benefits. Selecting the model that the U.S. Preventive Services Task Force is recommending. The lives saved is just about 500 life years gained, over 5,000. Advanced lung cancer avoided 550. And other less intense primary therapy, they don't have an estimate on that. I'll talk about that in a second. But there are risks. So you do a whole bunch of screens, right? You do almost 300,000 CT scans. You have a huge number of false positives, 70,000 false positives, some regular dose CT scan follow-ups. You do have some earlier lung cancer diagnoses, but the patient still dies at about the same time in a significant fraction of people, so there's some maybe increased anxiety for living with cancer for a longer period of time. And there's also some overdiagnosis. So some patients are told they have lung cancer when they never would have come to clinical attention. Okay, lots of screening guidelines. I'm going to pretty much skip over these because they look very much the same. But this is the one that the VA is going to focus on right here, the U.S. Preventive Services Task Force. It's a level B recommendation. Okay, the VA's pilot program. So the VA looked at that data and we had some discussions about what to do with it and decided that we would do a pilot program that is limited in scope to only 8 VAs, and we needed to do that in order to better understand how to implement screening across the entire system. The pilot is examining issues of logistics, not inclusion criteria, screening frequency, outcomes, or anything else, and a different protocol for screening might ultimately be recommended. So the possible outcomes of the pilot are a decision to implement lung cancer screening across all the VAs, what resources that will be needed to do that, and the best way to recruit patients, report CT scan results, track results, etc. So some of the questions that are to be answered by the pilot are, can we effectively identify the right candidates to offer screening in the course of routine care in the VA system? What will the uptake of screening be, and what resources, both technology and people, are needed to meet that demand? So we don't know in the VA if individuals will accept screening, and if so, at what rate, and that will greatly drive the resources needed to implement this, and this is very expensive, by the way. We as individual oncologists think we spend a lot of money when we write a prescription for a drug. This is way more expensive. So can we provide screening and follow-up, including the many individuals that are going to have benign nodules, and are the overall outcomes in our population similar to those that have been reported in other populations? In particular, there's some concern that the National Lung Screening Trial reduced the mortality rate from adenocarcinoma, but not small cell cancer, which was not expected, but also not squamous cell carcinoma. So in our population, where we have more of those two later histologies, we might not see the same efficacy. But this is the inclusion criteria that we're using: age 55 to 79. You have to have smoked at least 30 pack years. If you're a former smoker, you have to have quit within 15 years, and some exclusion criteria. If you've had a prior CT scan, you have to wait until you're at least 12 months out. You can't have symptoms of a possible lung cancer or ever have had a diagnosis of lung cancer to be in the pilot program. Receiving therapy for cancer, except skin cancer, and have to have a reasonable life expectancy, and also able to undergo evaluation and treatment if there's a possible diagnosis of lung cancer. And they're being recruited through their primary care physicians. So the CT is yearly until the pilot ends, which is 2 to 3 years. And then some other characteristics of that we're using is basically the same algorithm that was purported to be used at most of the national lung cancer screening sites. All right. And then one of the big questions, I think, for the VA is as we as physicians and healthcare providers know that the best way to prevent lung cancer is to stop smoking. So what is the impact of screening on smoking? So it appears as though it actually might have a beneficial effect. So if you have a negative screen, it does not increase smoking. That was a real concern. I think in the lung cancer study, this is a subgroup of the National Lung Screening Study, 87% at 1 year and 62% at 7 years, which is similar to the population quit rates. And the limitation was that there was no direct control in that. And then there's false positive screens, which increases cessation attempts. If you have a false positive screen, you actually are more likely to try to stop smoking and be successful at that. There are some other lung cancer screening modalities out there, and these are being piloted in different formats. And finally, here are the answers again to those 3 questions that you'll all need to know in the quiz. Thank you very much.